Hi, everyone. The goal of this lecture is to really overview GI drugs, especially the focus on the diseases that affect the GI, the signs and symptoms, and how, as nurses, it's important to manage the signs and symptoms of GI distress in terms of constipation, diarrhea, GERD, peptic ulcers, and such diseases you probably learned in pathophysiology. I'm going to do this lecture for a short 30 minutes, hopefully to cover three bigger aspects of this GI drug, if you want to call the signs and symptoms. I'll start off with acid controlling drugs, and then I will review things like constipation, diarrhea, and then the last we will review drugs for anti-nausea and vomiting. But before we start, I want to give you an overview of the GI system. If you think about the stomach and the sphincters that work above and below the stomach itself, we call it the esophageal sphincter, and then below we call it um, the sphincter between the stomach and the intestine, and there's another sphincter too, right? So those sphincters are really helpful to prevent the acid from refluxing below or above the stomach, because the pH of the stomach is 1 to 4, which is very acidic compared to our bodies, other parts of the body. For example, the pH of the blood is 7 point, right, plus. And then you also know the pH of other organs. For example, the lower GI versus the urinary tract versus the mouth versus the different parts of the body have different pH, right? So this is one of the most acidic parts. This is the most acidic part, the stomach, where we have the gastric cells that secrete parietal, that have gastric and the parietal cells and the mucosal cells. So the body tries to maintain homeostasis in terms of the stomach and the GI in order to secrete acids to digest the food that we eat by maintaining a certain pH. So the main job of the hydrochloric acid produced by the parietal cells is to predominantly help in digestion. I think keeping that in mind, you already know that smoking, NSAIDs, stress, and most importantly, H. pylori causes erosion or problems in the stomach gastric mucosa, thereby having the patients exhibit pain and sometimes GI bleed because of the peptic ulcer disease. You probably learned in your path and your physical assessment the signs and symptoms of peptic ulcer disease, the causes, the risk factors, and so on. So at this time, it might be good to go ahead and review those if you think it's important before you build on it, because a strong patho is a good build for strong pharmacology. So that being said, let's look at the first problem that we face in terms of signs and symptoms. One of the most common problem we face in our country here is GERD, gastric esophageal reflux. And the next one is peptic ulcer diseases too. So looking at these symptoms in terms of heartburn, pain in the stomach, pain radiating to the back, and things like that. There are some medications available. So first off, looking at the hydrochloric acids secreted by the parietal cells of the stomach layer, we can look at how we can either neutralize this acid that's secreted by using an antacid, or we could inhibit the proton pumps that are very responsible for making these hydrochloric acid. Or another group of drug is histamine 2 receptor antagonist. So these are the three classes of medications we will discuss in terms of acid controlling. If you look at antacids, most of these are available over the counter: calcium salts, magnesium salts, sodium bicarb salts, and alum salts, aluminum, that mean, right? I do not expect you to know each and every detail, because depending on the magnesium, type of magnesium or type of calcium or type of sodium, there could be different indications and different side effects. But for purpose of this class, I just want you to know that there are different salts. All the salts are the electrolytes that you learn for your fluid electrolytes, right? Sodium, calcium, and magnesium, except potassium. You don't get potassium for as an antacid. So instead of that, you can remember alum or aluminum, right? So these can be used to neutralize the stomach acid and promote GI defense. But purpose of this class, we want to be cautious on how to teach the patients if they are taking over-the-counter medications like antacids and how long and who should not be taking it and what is the risk and side effects. One really important thing to remember here is that renal patients, just like how you are very careful when you give potassium for renal patients, it's also very important to think about them in terms of these electrolytes. You see here, aluminum, magnesium, and calcium are very dangerous for patients who already are retaining fluid and also not able to excrete the excess electrolytes in their body, especially heart failure, renal insufficiency, and hypertension. Sorry, it's HTN. So then the side effects, if you look at the side effects, of course, some of them can cause constipation or diarrhea, right? And calcium can cause kidney stone. But one of the most really important thing here is to note is there a risk of metabolic alkalosis. So if you think of sodium bicarb, right? Bicarb can cause alkalosis. So if you remember your fluid electrolytes, you're probably learning about acidosis, alkalosis, or maybe starting to think of those, or you did in your patho. This is something really important to keep in mind. And also remember when we learn about antibiotics, right? We learn about tetracycline. So when we give medications to patients, when we give an antacid along, we need to make sure if there's any interaction that could prevent the absorption of certain important antibiotics or other medications that are intended for other reasons. So that's the thing with antacids, to be really cautious about its side effects and its interactions. I hope this was clear, but you can always go and read your book. If you want to know specifics of each salt, for example, magnesium hydroxide versus magnesium citrate versus calcium carbonate versus calcium. But for this class, I do not expect you to know those. The next group of medications that were invented or discovered were the H2 or histamine 2 receptor antagonist. Before the PPIs, these were the most commonly used. I'm not sure if anybody read recently in the news that one of the medications, that's Zantac, ranitidine, has received an FDA warning, and it has been pulled off the market because of its risk for causing cancer. Because one of the products in that medication has proven to cause cancer, so it's been pulled off the market. However, these histamine receptor antagonists, which end with the tidine, you say that cimetidine, famotidine, ranitidine, were the first group of drugs that were invented after the antacids to help in reducing acid secretion by competitively binding with the H2. So they block the H receptor, thereby the parietal cells cannot produce the acid. So that being said, there are some potential side effects of this medication. Of course, recently it's pulled off the market, but if you think of the elderly, we need to be very cautious when giving it because it can cause confusion. Another important side effect is the risk for thrombocytopenia. I really want you to know these, the side effects in the elderly and in general. Of course, you don't want people to smoke when they're already having, acid refluxes and peptic ulcer, but so smoking cessation becomes really important. The next group of drug is the proton pump inhibitor. So these also block the hydrochloric acid secretion, but in a different way. So the name gives it away. Both these classes, right, the H2 receptor antagonist and the PPI, they give it away. They say it's very clearly in the name itself, right? Inhibiting the proton pump by blocking the parietal cells of the stomach. So I think in this sheet in the acid controlling drugs, I think it's more important to focus on certain side effects and certain medications because the rest, it's pretty, straightforward. So remember that PPIs are used to treat Helicobacter H. pylori, meaning which is a bacteria. When you have a patient who presents with H. pylori positive, and that's a cause for their ulcer, you could give them this medication that's a proton pump inhibitor, and then combine them with an antibiotic. It's usually macrolide, like a thromycin, and then it's also combined with bismuth salicylate, or Pepto-Bismol. So kind of using these three medication and Flagyl too. So metronidazole, Flagyl is also used in treatment of H. pylori. It's usually a combination of 3 drugs. So there are some interactions. You have to be careful with this PPI that can interact with phenytoin and diazepam. with that being said, I really want you to like add a few things to this PPI, because more recently it has been found that with PPI intake for long periods of time, there's magnesium depletion. Okay, so when there's magnesium depletion, what happens is it can affect the heart. You probably know the importance of different electrolytes in the heart by now, but with PPI specifically, there's magnesium depletion. So in heart patients, be cautious when they take it. And long-term use can also cause osteoporosis. Because if it's binding to the absorption, which makes sense, right? When you bind hydrochloric acid in the body, it could prevent some absorption issues. I think that makes it pretty straightforward. So thereby causing things like deficiency states of like electrolytes, which can lead to osteoporosis. There are other drugs like sucralfate, carafate, which kind of protect the GI mucosa, because if you think of peptic ulcer, there's this disruption of the mucosa. So the sucralfate helps to protect the GI, which is a mucosal agent. So does misoprostol, but we have to use this very, very cautiously with pregnant women. It cannot be used. Simethicone is another medication that can also be used as a GI protectant. Then the last thing to talk about here is nursing implications, especially when we talked about where we should be not giving, or if we give it, what we should watch for. And then also to make sure that patients should not be eating after an antacid, right? And then elderly, and what do you teach for the elderly? So this is where sometimes you might be, having some struggles trying to like pick what is the most important teaching to be done here when a patient takes, maybe for example, ranitidine in an elderly versus, with a PPI with magnesium or heart problems, right? I think that's where nursing implications comes in. So it's one thing to know what is in the book, but the next thing is to be applied to a patient scenario, because nursing is a practice where we have to apply and be careful that it's evidence-based. All right, so the next page here, you have more acid controlling drugs, but even though they say these acid controlling, I would say these are bowel disorder drugs. And we can classify the symptoms as diarrhea, constipation. If you have been in any type of, or even at home, you probably know that most of us, one of most of the common symptoms that we have are diarrhea, it's constipation. In a regular GI problem list, right? So this page kind of gives some medications, lists some medications for anti-diarrheal, anti-motility. For example, if there's problem with, like constipation, or if there's severe diarrhea, right? And then probiotics, and then laxatives, emollient, and hyperosmotic. So for this, I think most of these are very straightforward. But for purpose of this class, I'm really asking you to focus on the probiotic. If you think of probiotic, right, these are very safe drug, because what happens is the natural flora of our body has some bacteria, right? For example, staph is present in some of our, our skin and tissue and stuff, right? But when the same staph enters the urinary tract, then if you're immunocompromised, that's where the problem starts, right? So probiotics are biotics like lactic acidophilus bacteria, which are present in the normal healthy flora. So if you have destruction of the mucosa, patients can benefit by taking a probiotic. So especially after taking long periods of antibiotics, the bacterial flora can lose its natural protection capability. Other than that, in this page, I would really want you to know the stool softener, which is Colase, right? So Colase is a stool softener given for constipation, and it's one of the most commonly used. You should know how this works. It softens the stool. Again, that's why it's called stool softener, right? So that's how it helps with constipation. Versus when you compare with the bulk forming laxative, which you see above that, right? So it's really important to know how that works. So the bulk forming examples are the psyllium or the methylcellulose, they create fiber, they kind of form high fiber inside the stool and make it bulkier. So that's why we call it bulk forming, right? So it absorbs water, helps in bulk forming. So thereby it's easier for patients who have problems with constipation. However, these can be habit forming. The last class is hyperosmotic. This is given when their patients are having a really, it's not usually used as a first resort, but usually when the others don't work, then patients might be placed on Miralax or polyethylene glycol, which increase the water content. So that means it's hyperosmotic, right? Lactulose is given when patients have excess ammonia in the body as well. So this is usually not very used commonly. So I think in this page, these are some of the important medications that I wanted you to know. I think you can add one more to this list for anti-motility, loperamide. So loperamide is given when patients have severe diarrhea, right? Imodium too is given when patients have severe diarrhea, right? So it's really important